Unit 11, Feeding and Eating Disorders. 11.2 Introduction. Eating is a major part of human lives and has also social and cultural significance. It is a normal activity in our daily life. Parents often complain about eating problems in their children. We all also have our specific food preferences. However, food and eating activity which are normally enjoyed by human beings can also have negative consequences and affect our psychological well-being. DSM-5 has listed feeding disorders and eating disorders in one category that represents disorders related to eating behavior. Both these disorders can occur at any age, though mostly seen in children and young adults. Feeding disorders involves unusual eating of substances without any nutritional value, whereas eating disorders involve problems related to eating normal food. Almost everyone has looked into the mirror and experienced dissatisfaction with their body weight at some point of time in their lives. Body dissatisfaction and weight concerns are common amongst women, especially during the adolescence and young adult stage. Although all throughout life, both males and females show some concern regarding their body weight and appearance. The hectic lifestyle of today associated with consumption of fast food and lack of exercise highlights this concern more. Body dissatisfaction may be healthy and adaptive in some individuals as it may motivate them to lose weight and change to a healthier lifestyle. Achievement of normal body weight through regular exercise and healthy eating is beneficial for our physical and mental health. However, in some individuals the concern about body weight is somewhat more extreme. They are likely to think they are overweight even when they are not. They may engage in excessive dieting and vigorous exercise to lose weight, which in turn may lead to negative social, emotional, behavioral and medical consequences for the individual. This drive for thinness leaves them distressed and dysfunctional, i.e., affecting their interpersonal, social, and occupational lives. Under these circumstances, the experience of intense body dissatisfaction is classified as an eating disorder. Eating disorders are defined as severe disturbances in eating characterized by a. Weight concerns, b. Body dissatisfaction, and c. Eating problems that are more extreme than the normal, causing the individual significant distress and dysfunction. DSM-5 classifies three major types of eating disorders. First, anorexia nervosa, in which the individual eats minimal food and the body weight drops to dangerously low levels. Second, bulimia nervosa is a condition in which the individual engages in episodes of binge eating, uncontrollable eating, and then indulges in self-induced ways of throwing the food out like vomiting, use of laxatives, or other attempts. Finally, binge eating disorder is a condition in which individuals binge repeatedly but the episodes are not followed by compensatory mechanisms to throw it out of the body. In this unit, we will discuss various feeding disorders and also look into the clinical features, causes and treatment of anorexia nervosa, bulimia nervosa, and binge eating disorder. 11.3 Feeding disorders. Feeding disorders consist of three types. Unlike the eating disorders, particularly anorexia nervosa and bulimia nervosa, which involve problems related to perception of body shape and weight, feeding disorders do not include any such disturbance in perceiving their body shape and weight. Pica, it involves eating non-nutritive substances, i.e., non-food items such as chalk, coal, paste, clay, paint, etc. These non-food items can be harmless such as ice, or harmful like paint, etc. It is usually seen more in underdeveloped countries than developed countries. Sometimes, it is displayed during pregnancy and may be accepted in the culture. However, if such feeding behavior persists over a month, it can be considered as disorder. Rumination disorder, as the term indicates, rumination means going over a thought again and again, or brooding over it, the person ruminates about the food by actually eating it and then re-eating it. That is, the person regurgitates the food eaten, re-chews and re-swallows it or spits it out. Here also, the diagnosis requires that it has lasted for more than a month and is not associated with any other medical condition or eating disorder. Avoidant /restrictive food intake disorder. It involves avoiding certain food items due to their disliking of the color of food, or any other characteristic related to food. Thus there is sensory aversion to particular foods pertaining to their look, color, smell, taste, or due to past unpleasant experiences associated with that food. As a result, the person does not get proper nutrition and it has adverse health outcomes. 11.4 Anorexia nervosa. Clinical picture. Anorexia literally means lack of appetite induced by nervousness, but this definition is a misnomer because it is not a lack of appetite but a fear of gaining weight. In bulimia, you will learn it in the next section, majority of individuals are within 10% of their body weight, however, people with anorexia are dangerously underweight. The defining feature of anorexia is that people are significantly underweight relative to their age, sex, developmental trajectory, and physical health. However, people may lose significant amount of weight because of many reasons, including medical reasons. But in case of anorexia, this significantly low weight of the individual is because of an intense fear of gaining weight or becoming fat. Although there is a popular misconception about people with anorexia, that they do not feel hungry, however this is not true. People with anorexia feel hungry and often think about food, but their intense dissatisfaction with their bodies drives them to almost starvation. People with anorexia are never comfortable with their body weight no matter how significantly underweight they might be. In fact, even staying the same weight, underweight, or gaining slight weight can cause intense panic, distress, anxiety and depression. Thus, people with anorexia show disturbance in the way they experience their body. For instance, they may have distorted body image, while others may see themselves as emaciated and skinny. They may continue to see themselves as fat. Similar to people with bulimia, their self-evaluation may be unduly influenced by their perceived body shape and size. In spite of being told about the life-threatening consequences of their low body weight, they may show lack of seriousness towards these concerns. DSM-5 has specified two subtypes of anorexia nervosa: the restricting type that includes individuals who diet excessively to limit the calorie intake, and binging and purging type, in which they rely on purging. People with restricting type would skip meals, eat slowly, count calories consistently, drink a lot of water between meals to feel full, dispose their food when others are not looking, etc. Anorexia usually begins in adolescence, when an adolescent perceives self to be overweight. They then start a diet that escalates into an obsession with thinness. Dramatic weight loss is achieved through restricted eating or by combining caloric restricting with purging. Box 11.1. Case study: anorexia nervosa. Anushka had always been a chubby child. Her friends and family always teased her for being fat. In particular, she remembered when she was in class 9th, one of her uncles commented about her body weight and shape: "You're so fat, who will marry you? Lose some weight." She remembers that she has always been discontent with her body weight, shape and size. In class 10th, she started actively looking for ways to reduce weight. Gradually, there was an increasing concern over growing fat. She started skipping 2 meals and would take only 1 meal and salad. She put up posters of female movie celebrities in her bedroom and would idealize them, often wishing to have bodies like them. She started exercising for 1-1.5 hours in order to compensate weight gain out of binging. She would binge on food 5 to 6 times a month and would regret afterwards and would try to induce vomiting. She even started smoking secretly to reduce weight, along with skipping meals as she was afraid of becoming obese. Her family noticed that she was obsessed over her looks, weight, and spent hours in gyms and dieting. Over next 6-7 month period, she lost up to 20 kilograms and looked frail, although she still found herself being fat. Because she was still unhappy with how she looked, she went for a liposuction, cosmetic surgery for removing excess fat, without informing her family, and even sold her gold necklace to pay for it. Her academic performance deteriorated. She failed her class 11th exams. Her social life was almost non-existent. She did not have time to be with her friends who would find her weight obsession too weird and extreme. Box 11.2. DSM-5 Criteria for Anorexia Nervosa. A restriction of energy intake relative to requirements leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. B. Intense fear of gaining weight or becoming fat, even though underweight. C. Disturbance in the way in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or denial of the seriousness of the current low body weight. Restricting subtype, weight loss is accomplished exclusively through caloric restriction, i.e. dieting, fasting, and / excessive exercise. The individual has not binged or purged in the last 3 months. Binge eating / purging subtype, the individual has binged, subjective or objective binge episodes, or purged in last 3 months. Associated features of anorexia. Anorexia is associated with serious medical conditions. One of the most common medical problems is amenorrhea or cessation of menstrual cycle in women. Other problems include dry skin, brittle hair / nail, sensitivity to cold temperature. Cardiovascular problems like low blood pressure and heartbeat can also occur. If vomiting is part of anorexia, then electrolyte imbalance can occur leading to heart and kidney problems. With respect to comorbidity, as with bulimia, anxiety disorders and mood disorders are common in people with anorexia also. Substance abuse is also a comorbid condition in people with anorexia. One anxiety disorder in particular, obsessive-compulsive disorder, OCD, often co-occurs. It has been noted that anorexia and OCD have some similar features. For instance, in anorexia there are intrusive thoughts about fear of gaining weight, and also individuals may engage in ritualistic behavior. Future research will be able to give us more clarity about whether the two disorders are truly similar or merely resemble each other. 11.5 Bulimia nervosa. Clinical picture. The word bulimia comes from Greek word bus, meaning ox, and limos, hunger. The core feature of bulimia is recurrent episodes of binging, i.e. eating large amount of food, typically junk food than most people would in the same situation, followed by use of compensatory mechanisms, vomiting, excessive exercising, laxatives, dieting etc., to overcome the guilt of weight gain. For instance, Princess Diana would have binge episodes in which she would eat up anything she could get her hands on and would then induce vomit to throw the food out. A typical binge and purge episode is characterized by the following: 1. Eating much more rapidly than normal. 2. Eating until feeling uncomfortably full. 3. Eating large amounts of food when not feeling physically hungry. 4. Eating alone because of feeling embarrassed by how much one is eating. 5. Feeling disgusted with oneself, depressed, or very guilty afterwards. Apart from eating a large amount of food in short duration, binging is also characterized by experience of lack of control. This feature was also present in binge episodes of Princess Diana, Initially started as a new method to diet, she found herself increasingly losing control with every subsequent binge episode. Another important criterion is that the individual uses inappropriate compensatory mechanisms to prevent weight gain. Based on the method used, bulimia can be classified as binging and purging type and binging and non-purging type. In the purging type, the individual induces vomiting, whereas in non-purging type, the individual uses other mechanisms including misuse of medicines like laxatives, drugs that relieve constipation, diuretics, drugs that result in loss of fluids through increased urination, enemas, or any other medications, long period of fasting and excessive exercise. Majority cases of bulimia are the purging type, and researchers have found little evidence of any major differences in frequency of binge episodes, comorbid disorders like depression and anxiety, and severity of the psychopathology between the two, and thus DSM-5 has dropped the distinction. DSM-5 has added a criterion that was not previously there in DSM-4. Self-evaluation in people with bulimia nervosa is unduly influenced by body shape and weight. People with bulimia believe that in spite of their various achievements and success, their self-esteem and popularity will be largely determined by how their bodies look. For instance, from the outside, Princess Diana was loved by all for her generous nature and charity work. However, she exclusively focused on the shape and size of her body, see Box 7.1. Box 11.3. Case Study, Bulimia nervosa. Princess Diana revealed that bulimia nervosa began for her a week after her engagement with Prince Charles of England. She recalled how her then fiancé, Prince Charles, put hand around her waist and said, "Bit chubby here, aren't we?" Princess Diana discovered that she could lose weight if she binged on food and then vomited it out later on. She recalled in an interview, "Anything I could find I would gobble up and be sick 2 minutes later." She felt thrilled at first at finding a new method of dieting, but increasingly found herself in a downward spiral. She confessed that her eating problems were intensified because of her troubled relationship with her husband. Years later, she was finally forced to seek help. Diana said during the 1993 speech, "From early childhood many had felt they were expected to be perfect, but didn't feel they had the right to express their true feelings to those around them, feelings of guilt, of self-revulsion and low personal esteem, creating in them a compulsion to dissolve like a despair in and disappear." In the speech, Diana commented about the possible role of expectations of perfection and low self-esteem in the development of bulimia. Later in life, Diana became an eating disorder awareness advocate. Box 11.4. DSM-5 criteria for bulimia nervosa. A recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following: 1. Eating in a discrete period of time, for example, within a 2-hour period, an amount of food that is definitely larger than what most people would eat during a similar period of time and under similar circumstances. 2. Lack of control over eating during the episode, for example, a feeling that you cannot stop eating, or control what or how much you are eating. B. Recurrent inappropriate compensatory behavior to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, or other medications, fasting, or excessive exercise. C. The binge eating and inappropriate compensatory behaviors both occur, on average, at least once a week for 3 months. D. Self-evaluation is unduly influenced by body shape and weight. E. Binging or purging does not occur exclusively during episodes of behavior that would be common in those with anorexia nervosa. Binge and purge cycle. The binge and purge cycle usually begins with excessive dieting, i.e., almost starving oneself motivated by a desire to look thin. During these early stages the person diets and eats low-calorie foods. Extreme diets can aggravate the associated negative emotions like anxiety and stress. Combined with hunger, anxiety can trigger a binge episode in which a person starts to eat junk food like chips, cola, chocolate, pizza, ice cream. While initially, a binge episode feels good, but soon enough the person starts experiencing shame and self-hatred over the loss of control. The person begins to vomit, fast, exercise excessively, or abuse laxatives. Even though people with bulimia are disgusted of their behavior, binging and purging persists. Associated features of bulimia. People with bulimia are plagued with negative emotions like shame, guilt, embarrassment, and self-deprecation. For this reason, eating disorders often coexist with mood disorders and anxiety disorders. Further, there are severe medical consequences of bulimia nervosa. Excessive vomiting can lead to dental problems, swelling of salivary glands, esophageal problems, whereas overusing laxatives, diuretics can lead to chronic diarrhea, or bowel problems. One of the most common side effects of abusing various medications as a compensatory mechanism for binging is dehydration. Continued vomiting can lead to electrolyte imbalance, cardiac arrhythmia, seizures, and renal failure, which can be fatal. Differences between anorexia nervosa and bulimia nervosa. First, people with anorexia who binge and purge are different from people with bulimia in being severely underweight, whereas people with bulimia are typically of normal weight. If a person who binges or purges also meets criteria for anorexia nervosa, she/he is given the diagnoses of anorexia and not bulimia. This is because there is greater mortality associated with anorexia than with bulimia. Second, unlike people with bulimia, people with anorexia binge smaller amount of food and purge more regularly. In some cases they may purge after every meal. Third, a typical person with anorexia would deny the seriousness of their condition, whereas a person with bulimia does not have this denial or a complacent mindset regarding his/her condition. Finally, it is not uncommon to find a feel of pride in people with anorexia regarding their diets, weight, and extraordinary control over them. However, people with bulimia are likely to be ashamed of both their eating issues and lack of control. Thus, anorexia is marked by ability to control food intake, while bulimia is associated with losing control over food intake. Prevalence. Eating disorders affect almost 9% of the population worldwide. According to APA, the prevalence rate is higher for bulimia nervosa, 1 to 3%, relative to the rate for anorexia nervosa, 0.5%. Studies in the Indian context have found that the rate of anorexia nervosa is 10 per 100,000 in Indian males, and 37.2 per 100,000 in Indian females in Tamil Nadu state. The age of onset is early adulthood, 18 to 21 years, with a greater number of women suffering from this condition than men. In case of bulimia, women receive 90 to 95% of the diagnoses. Men have later age of onset, predominantly gay or bisexual. Rates of eating disorders are higher in men who are in sports that require weight regulations. It is important to note that the condition may be underdiagnosed in men, as unlike women, men do not have the same need as to reduce weight or shape concerns. Their needs are concerned with muscularity. Eating disorders typically have a chronic course. Early childhood predictors include history of obesity and an overemphasis in family to be thin. They are difficult to treat and relapse rates are higher. However, recovery is possible over a longer period of time. Even when people recover, residual issues with eating remains, such as concern with body shape and weight and a tendency to binge and purge when upset. 11.6 Binge eating disorder. Binge eating disorder is marked by excessive uncontrolled eating which results in being overweight and obese. As Stunkard denotes, it involves repeated episodes of eating excessive amount of food without purging. That is why it is seen more in cases of overweight people, prevalence of 2.9%, as compared to 1.5% prevalence rate in people with normal weight. Another study reports a lifetime prevalence of binge eating disorder 2% in men and 3.5% in women. Binge eating disorder differs from bulimia nervosa in that it does not involve any compensatory behavior to purge the food out. Consequently, such people tend to be overweight and obese. One word of caution here is to differentiate obese people who are also into binge eating condition and obesity due to family genetic factors. The main symptoms include uncontrolled eating, frequent and excessive eating, lack of purging. Usually eat alone due to guilt and shame of eating so large quantity of food. 11.7 Causes of eating disorders. As is the case with all disorders, biological, psychological, and socio-cultural factors contribute to the development of eating disorders. However, the most dramatic factors influencing the development of eating disorders are socio-cultural factors. According to the diathesis stress model, biological diathesis, genetics or neurochemical features that lead to dysregulation in mood and eating behavior interact with psychological vulnerabilities such as low self-esteem, need to seek perfectionism, impulsivity, body dissatisfaction, and distorted body image, and environmental factors such as media-based pressures, child maltreatment, family conflict, social pressures, abuse etc. resulting in eating disorders. 1. Biological factors. The biological causes of eating disorders can be identified on the basis of the following: twin and family studies. Twin and family studies evince for the heritability of eating disorders. The tendency to develop eating disorders runs in families, i.e., biological relatives of people with anorexia and bulimia have increased rates of these eating disorders themselves. Studies suggest that relatives of people with eating disorders is 4 to 5 times higher, with rates higher for female relatives of patients with anorexia. Researchers suggest that there is a shared genetic composition for people with the different types of eating disorders, referred to as the broader eating disorder phenotype. However, eating disorders are not as heritable as are mood disorders and schizophrenia. A person might inherit a tendency to be emotionally responsive to stressful situation and as a consequence eat impulsively in an attempt to relieve stress. This biological diathesis may interact with social and psychological factors to lead to development of eating disorders. Biological set point. Our bodies have a biologically determined set point for weight that is difficult to change. Whenever we move away from this biological set point, sensation of hunger is created. The more we move away from the set point, the more and more hungry we become, encouraging us to eat and gain weight in order to return to the set point. Chronic dieting enhances the chances of an individual with bulimia feel irresistible urge to binge high-calorie food. Neurotransmitters. Serotonin is a neurotransmitter that is involved in obsessiveness, mood disorders, and impulsivity. People with eating disorders respond well to antidepressants that target serotonin, thereby implying the role of serotonin in eating disorders. However, it is difficult to identify whether disturbances in neurotransmitters are causes or consequences of the disorder. 2. Socio-cultural factors. The following are the main socio-cultural factors that can act as risk factors / causes of eating disorder. Media. All cultures recognize ideal images by which men and women are judged as worthy members of their sex. These images form an essential component of our body image, that is, how we think, feel, and behave with regard to our bodies. Media technologies, magazines, newspapers, television, movies, and now social networking websites, provide information about how an ideal body looks. Although, irrespective of one's gender, people are exposed to ideal body images in media, studies report that women are more vulnerable to body image disturbances than men. The body size of women in media is becoming unrealistically thin. Many young women are being regularly bombarded with these unrealistically thin models and actors. If we look at the body shape and size of Bollywood actresses from 1970s and compare them to current-day actresses, we would realize that the construct of ideal body for women has changed from being voluptuous to skinny. Further, use of technologies like airbrushing, digital alteration and cosmetic surgery further increase the unrealistic nature of media images of women as standards for self-evaluation. In many non-Western cultures, for example, in earlier times in India, fatness would be valued over thinness as a sign of prosperity. Thin people were considered to be sickly and forward/or incompetent. However, over time after exposure to Western media, many Indian women began to express concerns with their weights and body dissatisfaction. Activity 2, Ethnic Identity / Nativity and Eating Behavior. You can find that people belonging to different parts of India vary in their typical body size, shape and weight. For instance, people from Punjab have different body type as compared to people from the northeast part of India. Similarly, people from African continent differ in their body shape from people in Western countries like America or Europe. Do you think there will be any difference in the way these people perceive their body shape and weight respective to their nativity or place of origin? Will the socio-cultural factors like media have differential impact on them? Try to talk to a few such people and find out if the nativity of the person affects their perception regarding their body image and their eating behavior. Family influences. About 1 out of 3 patients with anorexia report family dysfunction, and it was a factor that contributed to their eating disorder. The following features were observed in families of people with anorexia: parental overprotectiveness, rigidity, marital discord, control issues, etc. Parents also exceptionally value thinness, dieting and physical appearance. It is common to find family members making disparaging statements about body weight and shape. Although it is difficult to establish causality between family dysfunction and eating disorders, as the direction could be other way round also. For instance, having a member with eating disorder may affect the family negatively, in turn leading to increasing family dysfunction. 3. Psychological factors. The main psychological causes of eating disorders are as follows: excessive focus on appearance and internalizing of thin ideal. The extent to which an individual places importance on appearance and internalization of thin ideal contributes to the development of eating disorders. Excessive focus on appearance is most predictive of a preoccupation with weight for young women, who are generally more prone to anxiety. Internalization of thin ideal means the extent to which one associates thinness with desirable, attractive, popular and being happy. Internalization of thin ideal is related to a wide range of problems that are thought to be risk factors for eating disorder, i.e., body dissatisfaction, dieting, and negative affect. Body dissatisfaction. When one's own body image does not match with the ideal image promulgated by the media, then one is likely to develop negative feelings and perceptual biases regarding how fat one is, especially young girls and women. Such biases lead women to believe that men prefer more slender shapes than they in fact do. Also, women feel more stringently evaluated by their female peers than they themselves do. Increased body dissatisfaction is not only a diagnostic criterion for eating disorders, it is likely to cause them. Dieting. Some researchers believe that dieting is a risk factor for eating disorders. This is because many women who developed eating disorders had a history of dieting. However, not all those who diet eventually develop an eating disorder. Some of the factors that mediate the relationship between dieting and eating disorders are body dissatisfaction, supervised diets versus self-started diets, and the negative emotional effect of failed diets. Supervised diets in people are less likely to be linked to eating disorders than non-supervised diets by people high on body dissatisfaction. In fact, researchers conclude that controlled and supervised dieting is related to reduced symptoms of bulimia. Negative effect. Experience of negative effect is a causal factor for eating disorders. Feeling bad makes us self-critical and we begin to magnify our flaws and shortcomings. It is common to find widespread negative self-evaluations like, "I'm fat, I'm useless, I'm a failure" in people with eating disorders. Negative affect is what maintains binge episodes, as people usually binge when they are stressed, low, or feel bad about themselves. Eating high-caloric food is comforting and helps them deal with negative effects temporarily. Perfectionism. People with eating disorders are high on the tray of perfectionism or the need to be exactly right. Perfectionist people are much more likely to prescribe to the thin ideal and pursue a perfect body. Perfectionism leads to rigid adherence to dieting that then drives the binge/purge cycle in bulimia. 11.8 Treatment of eating disorders. Psychological factors and socio-cultural aspects play a major role in contributing to the risk factors towards eating disorders. Hence focus needs to be on the psychological treatments. Though drug treatments have also been used, however, evidence for the same is not very strong. Psychological treatment. Initially, psychotherapeutic efforts towards treatment of eating disorders aimed at patients' low self-esteem and disordered patterns of family interactions and communication. However, these treatments alone were not very effective. More recently, short-term cognitive behavioral therapies have emphasized on targeting eating behavior and associated attitudes such as perfectionism and focus on appearance. Cognitive behavioral therapy for bulimia teaches patient the physical consequences of binge eating and purging and the ineffectiveness of vomiting and abusing laxatives for the weight control. They are then advised to eat small portions of food 5 to 6 times a day with at least a 3-hour gap between each portion to eliminate excessive fasting and consequent binging. Coping strategies for resisting impulse to binge and purge and arranging activities so that the individual will not spend time alone after eating a meal, are also taught. Inculcating a healthy body image in children. It is very important to develop a positive and healthy perception of one's own body in terms of shape and weight. Accepting one's body helps one to maintain a good self-esteem. Parents, family members and teachers can help in this by avoiding criticism, comparing, or expressing dissatisfaction towards the child's body shape, size and weight. They need to reassure the child, encourage the child to respect the body for whatever it is, and convey acceptance towards the child. This will help the child in cultivating good self-esteem and positive image towards their body. Relationship with food. Food is important for us to provide nourishment and help us in our growth and development. It provides us the energy to sustain and engage in different physical and mental activities. Hence, food is to be respected and valued. Developing a healthy relationship with food will help the child in changing their perception towards food and subsequently helping them to develop a healthy image of their body. Drug treatment. There is no evidence for use of drugs in the treatment of anorexia nervosa, however, there is some evidence of their use in bulimia nervosa, particularly the binging and purging cycle. The drugs proven to be most effective are antidepressants, however, drugs alone have not been found to have any long-lasting effects on bulimia nervosa. 11.9 Let us sum up. Let us now list all the major points that we have learned in this unit. Feeding disorders involve eating non-food substances which can occur at any age. Achievement of normal body weight through regular exercise and healthy eating is beneficial for our physical and mental health. However, in some individuals the concern about body weight is somewhat more extreme. They are likely to think they are overweight even when they are not. Eating disorders are defined as severe disturbances in eating characterized by a. Weight concerns, b. Body dissatisfaction, and c. Eating problems that are more extreme than the norm, causing the individual significant distress and dysfunction. DSM-5 classifies three major types of eating disorders: anorexia nervosa, in which the individual eats minimal food and the body weight drops to dangerously low levels. Bulimia nervosa is a condition in which the individual engages in episodes of binge eating, uncontrollable eating, and then indulges in self-induced ways of throwing the food out like vomiting, use of laxatives, or other attempts. And binge eating disorder is a condition in which individuals binge repeatedly but the episodes are not followed by compensatory mechanisms to throw the body out. Bulimia is characterized by recurrent episodes of binging, i.e. eating large amount of food, typically junk food, than most people would in the same situation, followed by use of compensatory mechanisms, vomiting, excessive exercising, laxatives, dieting, etc., to overcome with the guilt over weight gain. The binge and purge cycle usually begins with excessive dieting, i.e. almost starving oneself, motivated by a desire to look thin. Extreme diets can aggravate the associated negative emotions like anxiety and stress. While initially, a binge episode feels good, but soon enough the person starts experiencing shame and self-hatred over the loss of control. People with anorexia feel hungry and often think about food, but their intense dissatisfaction with their bodies drives them to almost starvation. DSM-5 has specified two subtypes of anorexia nervosa: the restricting type, that includes individuals who diet excessively to limit the calorie intake, and binging and purging type, in which they rely on purging. According to the diathesis stress model, biological diathesis, genetics or neurochemical features, that leads to dysregulation in mood and eating behavior interact with psychological vulnerabilities such as low self-esteem, need to seek perfectionism, impulsivity, body dissatisfaction, and distorted body image, and environmental factors such as media-based pressures, child maltreatment, family conflict, social pressures, abuse, etc., leading to the development of eating disorders. The best course of treatment available for eating disorders is a combination of drug treatment, though not used much, and cognitive behavioral therapy.